Welcome to the Dr. Lexi Show, where I break down pregnancy topics into simple terms to help you advocate for yourself and your pregnancy. I'm Dr. Lexi, a board-certified OBGYN and maternal fetal medicine specialist, which just means a high-risk pregnancy doctor. And today we are coming to you with a special guest for our YouTube channel. Today we have Dr. Stephanie Martin joining us. Hi, Dr. Martin.
Hello. Thanks for having me. I'm really excited to be here.
Thank you for coming. So sometimes we have guests that come on to talk about their pregnancy or to talk about their profession. So if you could give me and the listeners a little bit of a background as to where you're coming to us from and what your field is and all that information.
Sure. I am also a board-certified maternal fetal medicine doctor and OBGYN specialist. And my area of expertise and my passion is all about the very sick pregnant woman. So I love taking care of critically ill pregnant women. And beyond that, it's about preventing complications and preventing bad things from happening and for mom and baby. But my area of passion is really about making sure mom is okay. Usually if you make sure mom is okay, baby's often okay as well.
I love it. And everyone should know as well that Dr. Stephanie Martin is one of my mentors. And maternal fetal medicine, we're going to do some questions in just a little bit, but I want to make sure that the listeners understand, if you were to explain what maternal fetal medicine is to a patient or a lay person who's not in the field of medicine, how would you describe what it is?
That's a great question. And I get asked this a lot by patients and when I have to introduce myself to people, I'm on an airplane or whatever, and they're like, what on earth is a maternal fetal medicine specialist? Basically, what we do is take care of pregnancies that have gone beyond normal. So something is either definitely wrong or potentially wrong. And that could be mom or baby. So for example, many of us will see patients in the office where the OBGYN or the family practice doctor or the midwife thinks there might be something going on with the baby. Maybe it's not growing well, or maybe they're worried about a birth defect. And then they send them to us to do a detailed ultrasound and figure out what might be going on. On the flip side, we often see moms, and this is where my passion comes in, with potential for complications during pregnancy. Some of the most common things we see are high blood pressure and diabetes, being of advanced age. I hate that term.
Everyone hates that term.
But, maybe you're in your 40s. Last week, I saw a patient in her 50s who was pregnant. So, or maybe you have multiple babies, or maybe you had a bad complication in your last pregnancy. Some women come close to dying during their pregnancy. Some people bleed heavily. Some people are in the hospital for a very long time. And so they come to see us to figure out what do things look like during this pregnancy and how do we keep those things from happening again if we can.
Right. And so when you see a patient, the other thing, the question I get a lot about our field and what we do as maternal fetal medicine specialists is, how are you different from my OB? So I understand what you kind of said, but I know that every city, every state, every institution is a little different in how they handle that. So when someone comes to you and they say, well, so do I just come to you now? How do you kind of navigate that?
Yeah, that's a little more complicated. Yeah. But the bottom line is I kind of jokingly tell people, you don't want me to be your doctor. Because if you're needing me to be your doctor, that means something is not going well with your pregnancy. You have now bumped up into such a high risk level that it's outside of the training and experience of a general OBGYN. So it kind of, I like to think of it as a pyramid. So you've got a fundamental base of knowledge that everybody shares: midwives, OBGYNs, family practice, maternal fetal medicine doctors. And we can all take care of those very low risk patients. But then when you start adding in risk, the need for more education and training becomes even more and more important. So maybe you escalate from a midwife to an OBGYN. And then there's a point where your risk is high enough that the OBGYN no longer has the training or experience to take care of those problems. And then it escalates to a maternal fetal medicine doctor. Now, beyond us, then we're going to get other specialists involved, like maybe a heart cardiologist for the heart specialist or a pulmonologist if somebody's got lung disease, et cetera. But we're still kind of that core specialist. Yeah. But it's going to vary to a certain degree depending on where you are and what your OBGYN's level of training and expertise is. Some OBGYNs have a lot of experience taking care of really high-risk patients, and they partner with the maternal fetal medicine doctor very, very closely, but they're still totally in their wheelhouse. They can absolutely take care of those complications. And there are some OBGYNs who are not comfortable.
Yeah.
When I'm talking with my referring docs, I always say, look, if you have any doubt, if you have any questions, send them to me and let me help you figure out whether they're too high risk or not.
Yeah. Yeah. I think that's perfect. And it kind of segues into, as a patient, how do you know if you're being cared for in the right fashion? Like, do you need an MFM doctor, a high-risk pregnancy doctor? And those are some of the things that you'll find on the website to look into is like, do I need to ask certain questions and do I need to see a high-risk pregnancy physician at any point? And you can see a download on the website too, drlexihill.com/advocate. And what it is it's 13 questions you can ask your OB provider. And it's for anybody in their pregnancy. And it kind of helps you just start those conversations just to see, okay, am I with an OB that's going to keep me the whole time? Is there something that makes my pregnancy, quote unquote, high risk? And if so, what is it? And it kind of gives you the ability to kind of step and advocate for yourself just a little bit.
That's really, really important because, I mean, you and I have both had patients who came to us too late.
Yeah.
We should have seen them earlier in the pregnancy. And they'll say, look, I tried, but my OB he didn't want to send me to you. And so you will have that sometimes. So you really do have to feel comfortable advocating for yourself. And, our goal is not to take you away from your OBGYN. Our goal is to make sure that you and your baby are getting the right care for you. Now, risk, I want to comment on risk because risk is a very, very individual thing. So what the patient might consider high risk is not necessarily what the OBGYN might consider high risk. Mm-hmm. And it may not require you to see a specialist like us, but it might. And so don't be afraid to ask those 13 questions and figure out, am I in the right place? Because just coming to see a maternal fetal medicine doctor doesn't mean you're going to be taken away from your OBGYN. In fact, most patients that we see don't need to leave their doctor that they're with.
Right.
Sometimes they do. Sometimes they're too high risk and maybe they need to deliver at a different place than they planned because they were higher risk than everybody anticipated or with a different team. But it's all about making sure mom and baby are safe.
Yeah. And what Dr. Martin brings up too is something that I learned from my patients. I never really differentiated my patients into being high risk or not. But a lot of times when they come see someone that's a high risk obstetrician, the first question is, am I high risk? And sometimes I'm like, sometimes you're not. Sometimes you come in just to get something checked out, or sometimes the OBGYN send them to our offices for an anatomy ultrasound for screening, not because anything's truly going wrong, right? And so I've learned that it's nice to explain what makes you considered to be high risk when you're coming to visit. And when you leave, would you still fall into a category that would be a higher risk category? Do you kind of try to do that to stratify it a little bit?
Absolutely. And I'm a very visual person, so I draw a lot and I use my hands a lot. It's hard for me to keep my hands down right now, but basically I'll literally show them and I'll say, look, here's low risk because there's no such thing as a no risk pregnancy. Every pregnancy has risk.
Well said.
So here's low risk and here's high risk. And I've got one hand down low and one hand up high.
Thank you.
Then I'll say, here's where you are on this risk scale. Maybe you're down here close to the low risk. Maybe you're up here close to the high risk, or maybe you're somewhere in between.
Yeah.
And sometimes I may not even know if you're too high risk for your OBGYN or not. And then those cases, I'll just call and we have a conversation and I'll say, this is what needs to happen. Tell me what your resources are, what your comfort level is. Mm-hmm. Many times the OBGYN will say, I think she needs to be seeing somebody else. And many times they'll say, we got it covered, we got it handled. And then I will be very clear, okay, great. If these things change, then I need to get involved again. Or I'm going to stay involved and I'll see her every 2 weeks, every month, every trimester, whatever the plan may be to kind of check back in. And that's a joint plan that needs to be made, especially for the higher risk patients.
Yep. And just saying the word plan, like having a plan. I mean, so many times friends of mine and then patients are like, I have no idea when my next appointment is. I don't know if I do glucose screening, when I do it, where I go, who I ask. So a lot of what I feel like I'm doing, and maybe you're doing too, is helping a patient or even a friend to ask the right questions to navigate their ship a little bit, because there is a disconnect sometimes between patient and provider, because sometimes provider assumes patient knows certain things and patient assumes provider is doing certain things behind the scenes and just not telling anyone. So there's kind of like a little right hand not talking to the left hand some, right?
Super common.
It happens a lot.
Super common. And I think it's really important that everyone understand it's okay to advocate for yourself. And if your doctor gets upset because you're doing that, then maybe that's the problem. Maybe there's not a good fit there.
Mm-hmm.
I have yet to meet a doctor that doesn't care about their patients. Every doctor cares about their patients. And frankly, every doctor wants to spend more time with their patients, but we all know that healthcare is challenging.
Mm-hmm.
And so in order to make sure you're getting what you need, don't be afraid to advocate.
Yes, I love it. And I always tell people too, if you are the person that's like, I had all these questions, I forgot them. I always ask people, just put them on your phone. That's not a problem to bring it out because you'll be efficient in the time that you have with that provider, nurse practitioner, midwife, whomever, because you're not going to have them there for a long time, right? And so when you have it, utilize that time as wisely as you can, which is fantastic.
I love phones now. Yeah. When everyone first started bringing them into the office, I hated them because it just, people would text or do other things or take calls literally while we're having a conversation, which is just kind of breaks the rhythm and it's a little distracting. Now when people pull out their phone, it's because they're looking at their notes and they want to ask questions and they're engaged.
Yeah.
You know, the other thing I love about phones, everybody's got access to their patient portal now.
That's true.
So
that's true.
It's not unusual for me to see a patient and they come to me and I don't have all the information I need.
Time. But they can pull it up on their phone.
They do on their phone.
That's right.
And I can often interpret what's happening by looking at their own portal. I'm like, can I have your phone? I'll take a look. Oh, yes, this is what this means. And can you email that to me? And
Exactly. I've actually tell me if this has happened to you. I've had a patient I'm talking to. I do telemedicine full time. So I'm not in person. I'm on a camera with them. And there was someone in the back of the room. And I always introduce myself to anyone in the room. So I knew this was the patient's sister. And I can see her on her phone. And I'm like, oh, she's kind of not engaged in our conversation. That's fine, whatever. She's, playing a game. And then when I finish my consultation with the patient, I always say, does that all make sense? Do you have any questions that I can answer on what we talked about today or your follow-up plan? Clear questions, right?
That's great.
So that there's not just this open-ended confusion, right? So no questions. I'm doing fine. Thank you so much. The sister in the back of the room says, yep, Google said everything that she said, so I think your plan's good. So she was
approved by Dr. Google.
Approved by Dr. Google. So I felt really, really kind of, it could be intimidating, right? That the patients are checking you or whatever, but I'm like, that's great. If you see something online that brings you pause or you're curious about it, or maybe there's a study you saw and I can share with you, yeah, that study's one study. Maybe we are not going to do that for our plan, or, oh, that's a study I haven't heard of. Thank you for letting me know and we'll look into it. Because I think if you involve them in their care, I mean, it's their body, it's their pregnancy. How great, as opposed to just kind of what it used to probably feel like doctors here, up high, patients here, down low, and you do what we tell you. That's not medicine to me.
Yeah, I've never had an issue with patients coming with their own perspective and wanting to know my perspective on whatever it is that they're reading. And again, if you have a provider that you're with who is not open to that, and you want them to be, then it just might not be a good fit. And that's totally okay. That doesn't mean they're a bad doctor. It doesn't mean that you're a bad patient. It just means not right fit. Maybe we can find somebody that you have a better relationship with and you feel more comfortable having conversations with, because nobody should be shut down if they have questions.
No, for sure. Okay, so speaking of questions, we're going to go through some random questions today. So just so everyone knows, Dr. Martin and any guest I have on has no idea what these first 10 questions are going to be. And then I'm going to follow that up with 10 true-false questions.
Uh-oh.
So 20 questions total.
Am I getting graded?
No grades. Everyone's a winner. Everyone gets 100%, no matter what. All right. Are you ready?
I'm ready.
Okay. Question number 1. What does the abbreviation OB/GYN stand for?
Obstetrics and gynecology. And obstetrics is the pregnancy side, and gynecology is the non-pregnant side of female healthcare.
Thank you. Great answer. It is correct. Question number 2. What do the letters MFM stand for? Because we are both MFMs, right?
We are both MFMs. And if I get this wrong, maybe I should lose my board certification, right? Maternal fetal medicine.
Very good. Question number 3. How does a provider come up with your due date during a pregnancy?
Guess. No, I'm kidding.
Kind of, I mean.
Yeah. So we start with your last period, the first day of your last period, and we want to know if it's regular and predictable, because the first day of your last period will predict when you ovulated. And you generally ovulate 2 weeks after the first day of your last period. So from there, we can calculate out essentially 9.5 months. Pregnancy's not 9 months. Pregnancy's 9.5 from conception and 10 months from the first day of your last menstrual period. And this is where people get really confused.
Yeah.
So that's how it works. How we actually do it is we put it in a little program or an app or whatever, and it tells us what to do.
Yep.
So to make it even more interesting, we take the first day of your last period and we figure out your due date from that. Then we use ultrasound to say correct or not correct. And how your ultrasound is very rarely right on with the due date established by your period. But we have a range of what is normal. And the farther along you get, the wider that range is. So the best time to establish due date is in the first trimester. That first trimester ultrasound will either say, yes, the period date is correct, or no, it is not. And if you don't have predictable monthly cycles, then we don't use your period at all. We stick with ultrasound, and ultrasound gives us the date. And once your due date is established, we don't change it.
I love that. Because how many times do we always hear like, oh, so my ultrasound in the third trimester when I'm 34 weeks, we're changing, my due date's different, right? Because the baby measured big or small. This is a fantastic point that is in the advocacy sheet to talk to your provider about, because you want to know your due date early on so that you can plan your life and know how many weeks you are and make sure everything's going well and move forward, right? And not have this confusion of when the due date is, and know what it is early on. There's also a wonderful YouTube that's already up right now that you can check out that explains this in a little more detail. That was perfect detail. And it takes it and it gives examples. And what Dr. Martin's talking about we look at the period, if we know that you have regular menses and they're kind of on a good cycle for you. And then we do this ultrasound and then we decide. There's a beautiful table on there that takes you like step 1, step 2, step 3, so that you can talk to your provider too, because we sometimes, I know I do, and I know you do, you get someone in the second or third trimester and they don't know their due date and you can't figure it out from the records and you have to do like a wild goose chase. So if we're having a wild goose chase, I can understand how confusing it is as a patient to know what your due date is and have someone truly explain it to you.
You know, it's so important to understand that due date, because the due date really, that sets the standard for everything we do in your pregnancy. So it's important for the patient, obviously. You know, everybody wants to know their due date for all the obvious reasons. But from a medical perspective, it's crucial, because we determine if your baby's growing appropriately based on that due date. We determine how long it is okay for you to stay pregnant based on that due date. Everything is based on that due date. So the earlier we know it, the more accurate it is, and the better we are able to make decisions with you about what's best for your baby and for you, and not accidentally deliver somebody too early, right, or accidentally let somebody go too long.
Yeah, exactly. And it starts early on. The earlier you know your due date, the better. It's great. All right. Question number 4. When is a pregnancy considered term?
You're asking such complicated questions.
But the basic question, the basic answer to this, not the, detailed.
The complicated answer.
The basic, like if your doctor just says to a pregnant individual, did you have a term delivery or preterm delivery? Just what is the gestational age that makes it considered term?
So term is after 37 weeks of pregnancy.
There we go.
Your due date is at 40 weeks of pregnancy. But 37 weeks to 40 weeks is a term pregnancy, and anything less than 37 weeks is considered preterm.
Perfect. Thank you. See how these things should be, like we give individuals like a form to fill out when they come in, and it says term, preterm, and you're supposed to fill out all your prior deliveries. That's confusing because it doesn't say 37 weeks. It usually just says term, which is very, very confusing. Okay, question number 5. What is a normal fetal heart rate?
I love this question.
I love asking this question.
This gets asked so often. It's asked so often that I've trained my ultrasound technicians, my sonographers, to say the baby's heart rate is X and that is normal, because it sounds so abnormal. So essentially anything between 110 and 160 beats per minute is normal for a baby. And that is essentially double that of your heart rate.
Yeah. It's fantastic. I love it. Okay, thank you. Question number 6. What is antenatal testing or fetal well-being testing?
Yeah, so if your doctor thinks that you are at increased risk for having a fetal demise or a stillborn baby, then they're going to want to monitor that baby very, very carefully, usually starting sometime in the 3rd trimester. So, and I don't want you to mistake higher risk for stillborn baby to mean high risk for stillborn baby. So even when we say somebody has high risk to lose their baby, the overwhelming majority of the time, nothing bad happens. So we are monitoring the just in case because your risk is higher than somebody who doesn't have whatever medical problem you may have, like high blood pressure or pre-existing diabetes, for example. So when we need to check on the baby's well-being, we will do periodic evaluations of the baby. Usually once or twice a week, we're going to look at the baby either with ultrasound or monitoring the heartbeat with the belts. We call that NSTs or non-stress tests. So that's going to happen in some combination of one or two times per week from whenever we decide, usually somewhere in the 3rd trimester, most commonly around 32 weeks or so. And then we continue that up until delivery.
Yeah. And this is something I bring up because this is a term that if you have a pregnancy, let's do an example here and say a pregnancy is 40 years of age. It's my first pregnancy and I had IVF. And some of those things are associated with a slight increased risk associated with stillbirth.
Right.
And so I would want to be able to ask my provider, am I a candidate, right? Because you want to open the door to them. Am I a candidate? Am I someone who needs to have fetal well-being monitoring, antenatal testing, and that's a yes/no question. Then it's the follow-up question of how are we doing this? Because Dr. Martin even said you can do it once a week, you can do it twice a week, you can do it with an ultrasound, you can do it with a non-stress test, which are these belts. I've created these handouts that explain it as best I can because it is complex and confusing to say the least, but the basic advocacy handout even says just to open the door and ask the question because you would like to know earlier on if you're going to be coming into your OBGYN office or somewhere else 2 times a week for 3 weeks, 2 weeks, 2 months, whatever, right? You want to plan ahead because you might need to check with your job and check with your family and get a sitter or do, I think we forget sometimes how many appointments pregnant individuals have and we just ask them to follow up and, we aren't there to help them with all the other bits and pieces, but that's a lot of appointments. Right?
Quite frankly, I'm always surprised at how little pushback I get when I'm like, okay, and we're going to start seeing you twice a week. And everybody goes, okay. If it was me, I'd be like, I'm sorry, what? When? Huh? Yeah. I need details. Can I make those appointments 6 months in advance?
It's a lot. Exactly.
Yeah, it is a lot.
Yeah.
Well, and part of the reason that this is confusing is that our professional societies that recommend management and say this is the best way to take care of patients have given us a lot of room and there's a lot of right ways to do monitoring.
Yeah.
And so there's typically, it'll be based on kind of where you live and what the practices are in your community. As long as it's being done, it's kind of hard to do it wrong.
Yeah. And that's why this question on this advocacy sheet is exactly what Dr. Martin is saying is not just am I someone who needs fetal monitoring, antenatal testing, it's called so many things, right? Fetal well-being testing, I like to call it sometimes. But where am I going to do it? How frequently? When do I start? When is the endpoint? When am I delivering? That leads into those questions because it's not just a blanket statement for, fetal monitoring is this. It is so many various possible items for this well-being testing. So lots of questions involved.
Absolutely. And to point out, if you are higher risk for stillbirth and you need to have this monitoring done, that doesn't mean you need to be with a specialist necessarily. You don't necessarily need to be with an MFM. OBGYNs do this all the time, and it's absolutely okay. But sometimes there can be challenges when you're maybe seeing both and wanting to know, like, well, who's doing what? So, and it can get missed. If I'm the specialist and I think that the OBGYN is doing it and the OBGYN thinks I'm doing it, if the patient is not going, why isn't someone doing that? It can be missed. Even though we write it in our notes, even though we, document it in the ultrasound reports, et cetera, it can be missed. So it is super important that the patient understand what needs to happen for their baby and for their pregnancy.
Absolutely. And it can be done at the OB/GYN office, just like she mentioned. And sometimes in smaller towns that I service, the hospitals are involved so that you go to the triage area and that's where you get a non-stress test done where they put the belts around your abdomen. So it is just all over the place.
Yes.
And it's really, I think, for us to talk to the patient so the patient understands so that the patient and OB can talk and everyone is on the same page.
Absolutely.
Which is great. All right, question number 7. How does an ultrasound estimate the weight of a fetus?
So essentially what we do is we measure around the baby's head and across the baby's head. So we make a couple of measurements of the head. We measure the waistline and we measure the upper arms and the upper legs. And then there are computer programs in the machine itself that take all that information and translate it to an estimated weight. So I always tell patients, we're not weighing your baby. We're estimating the weight of your baby. And there's a lot of things that can influence that, but it's pretty good. I mean, it's not that wrong, but the bigger the baby is, the more likely we are to be wrong.
I think people think the opposite, right? Like the bigger the baby, the easier it is to measure, but your percent risk of being off kind of increases as the babies get bigger.
Absolutely.
So, all right, question number 8. What makes up amniotic fluid?
I love this one.
I know.
It's baby pee.
It's baby pee.
It's baby pee, and then they swallow it.
And then they swallow it, and then it goes into their little tummies. Question number 9. Who should be offered Down syndrome screening in a pregnancy?
Anybody who wants it. So anybody is at risk of having a baby with Down syndrome, and the risk increases as we age, but it absolutely can happen to anybody. So anybody who wants to be screened and know if they're high risk or not should absolutely be screened.
More specifically, though, who should be offered screening?
Like every single patient should be offered screening.
And that's what I think is a big thing that I feel like patients sometimes think that they have to ask for it. And this should be something that you should be offered, right?
Absolutely. Everyone needs to be offered. Doesn't matter how old you are. Doesn't matter your family history. The most common response I get from patients when we start talking about this is,
no one in my family has it. Yes.
And I tell them I like to use analogies, and I don't want to be flippant, but the closest analogy I can think of that is that's like saying, my mom never got in a car accident, so I'm never going to get in a car accident.
No, but that's actually, because it's
totally random.
Totally random. So there is Down syndrome that can be quote unquote inherited, or as people kind of term it, genetic, right? Mm-hmm. So when you have somebody say, no one in my family has it, and they're like, so I don't understand though. I thought it was a genetic condition. So how much of it would you say to them is like the random thing versus there truly are some that can be genetic?
More than 99% are random, out of the blue, nothing to do with anything else. It's very rare to have Down syndrome that is passed through families. We all know those scenarios. We know how to test for it. We know what to look for, but it's incredibly rare. But the testing that we're doing is looking for random, out of the blue.
And I'm so glad that we talked about that, because I think that's a huge point for people to understand. Question number 10, what is considered a normal length of a cervix in pregnancy?
Greater than 2.5 centimeters long, which is about an inch, between 16 and 24 weeks of pregnancy. So cervix lengths beyond 24 weeks really aren't that helpful. And cervix lengths less than 16 weeks. People ask me this all the time. Why can't you do my cervix lengths now? Because it was short in my last pregnancy, or I had an early baby, or whatever. It's because we can't tell the difference between the uterus and the cervix. And so it makes it really challenging. So 16 to 24 weeks, it should be longer than 2.5 centimeters.
Love it. And this part I'm going to do separately just to ask you a question. So interestingly, I've talked to someone recently who is 20 weeks. They had an anatomy ultrasound. The only thing they were told at their anatomy ultrasound was that their cervix was normal. No one told them the length, which is pretty common. They don't always get the length. But she was like, I'm super happy because I know that it was normal, right? And I said, well, so how was the ultrasound since you had this anatomy ultrasound? 39, 40-year-old individual, first pregnancy, that's considered high risk, right? By definition, okay? So they're getting this detailed anatomy ultrasound. And when I asked about the ultrasound itself for the fetus, the answer was, I'll get results in 5 to 7 days.
Wow.
Yeah. So thought that was interesting, right?
Yeah. So it's tricky because it depends on who. So first of all, the ultrasound technicians are performing the ultrasound, but they cannot interpret the ultrasound. Now, in our practices, our ultrasound technicians are highly experienced and trained, and all they do is complicated pregnancy ultrasounds. And so they are very good at picking things up, and they're also very good at communicating what they're looking at with the patient without making diagnoses, okay? Because that's for the physician. But it's not unusual for the techs to maybe have less experience or be told by the physician that they're working with that they cannot discuss anything on the ultrasound with the patient. And then it has to go through the whole process of the physician to read it.
Yeah.
It's really not acceptable for an ultrasound to sit that long and not be communicated to a patient, in my opinion.
Yeah, I agree with that. As we talk about how OB/GYN offices and maternal fetal medicine offices are different in different cities and states, that just shocked me because we do, it is a medical procedure. An ultrasound's a procedure, right? So someone's doing it and then another person is interpreting it. The ultrasonographer's doing the ultrasound, the physician is interpreting it. Most of the times in our field, the physician will read that ultrasound and talk to the patient, or at least tell them the results or go through them within that appointment time. Would you agree with that?
Yeah. So
on average,
if we're seeing the patient for a consult, then we're going to have a conversation about the ultrasound. But many times, you, as a patient, you've experienced this where you just have your ultrasound and you never see the doctor. Mm-hmm. So someone has to communicate the results to you. And that's going to be highly, highly variable. It might be your general OBGYN getting the report from us and saying, yes, everything was normal. It might be the OBGYN in your own office who read the scan and just tells you at your next appointment, which who knows when that is from when the scan was. I can tell you in the practices that I've worked in for many, many, many years and all over the place, the ultrasound technicians tell the patient everything looks good, but the doctor still needs to review it and will let you know if there's a problem. But if they do think there's a problem, that is communicated to a physician before the patient leaves.
Yeah, yeah.
And that's, I think, for pregnancy, it's kind of hard to leave that woman hanging,
right?
Or thinking everything's normal or wondering if everything's normal or not for all that time. So I know it happens, but I don't, it's not how I like to practice.
Yeah. And just like you said with the ultrasonographers too, they are not the ones interpreting the images. So don't be discouraged if you have an ultrasonographer that isn't telling you anything about the scan. If they're kind of more quiet or not doing that, they've been asked to do that, right? Wouldn't you agree?
Yes.
So, okay.
Yeah.
And I know that's a hard job for them too, right? Because
it is, because imagine they're essentially trying to perform a CAT scan. Okay. So they are looking at this baby and they've got a huge checklist of body parts and measurements that they have to obtain in a relatively short period of time that they have to do. Meanwhile, they're trying to engage with the patient and talk to them. And very often there's family members or even children in the room, which are more distractions for them. So some of them, we're all different people, right? And some of them are better able to have conversations while they're doing it. And others really have to focus to make sure. But remember, the priority is making sure that they're able to see what they need to see on your baby. And it's always great when they can have a social interaction with you. Yeah. But you're right. They're not making diagnoses. They're just gathering information about your baby. And that's being communicated to the doctor, who's then got to interpret it and create a report for it.
Yep. Okay. Thank you for explaining all those things.
Yeah.
And we're going to go into 10 true/false questions.
Okay.
Really quickly. All right. True or false? A fetus can have hair while in the womb.
Absolutely. And we can see it on ultrasound.
That's right. Question number 2. A fetus can hear.
They absolutely can hear.
Question number 3. If a pregnant individual eats sugar, this will wake a fetus up if they are sleepy. True or false?
Can I take a middle road?
If you had to go true or false, which would you say?
I would say true. So
now I want to hear more.
Yeah. So here's the thing. If you have, I know what you're getting at. Mm-hmm. The myth is this. The myth is that, oh, my baby's sleeping. Let's just drink something cold or have a soda or orange juice and it'll wake the baby up. No, babies sleep in cycles of usually 20 to 40 minutes. And if they wake up in timed with that, then it's because they randomly woke up. But I tend to read too much into questions. This is why
true and false is hard for you,
tests.
right?
It's very hard for me. But on the other hand, and this is why I say in the middle. So drinking something cold, drinking something loaded with sugar does not wake a baby up out of a sleep cycle at all. But when you put sugar into your blood, so if you eat something with a lot of sugar in it, that goes directly across the placenta into the baby. And this without any obstruction, it just goes from mom to baby, mom to baby. And this is why pregnant women are more likely to get low blood sugars, because it's like they've got a drain of all their sugar out of their blood right into their baby. And it's also why women who have diabetes and have high amounts of sugar in their blood, their babies are just like they're eating candy the whole pregnancy. And so they're just packing on the pounds and getting really, really big. So no, it's not going to wake the baby up, but the sugar does go directly into the baby.
Yeah. Thank you for that answer. It's so hard to get a true false out of you. Okay, let's see. Question number 4. Everyone should be screened for diabetes when they're pregnant.
Everyone should be screened for diabetes while they're pregnant 100%. There are certain people who are at higher risk for diabetes, but everyone needs to be screened for it. We've all had patients that shocked us when they had diabetes, right? And the current recommendations are that everyone be screened.
So that's true or false? And everyone should be screened. True. Okay. Question number 5. Everyone should be screened for thyroid disorder when pregnant.
False.
Love it. They should not. Love it. Question number 6. Someone with 2 prior C-sections, they have to have another C-section.
False. Can I say that again?
Yes.
False.
Thank you. This is great. Question number 7. Twins that are the same gender are always identical.
False.
False. Actually, I had someone get that right that's like not a physician, and I was like very impressed.
Yep.
Very impressed.
Yep, that's false.
Question number 8. No cheese is safe to eat during pregnancy.
False.
False. Question number 9. Someone trying to get pregnant should start taking folic acid before their pregnancy.
Absolutely true.
Fantastic. We actually have a little article we're going to review later.
Mm-hmm.
They've somehow decided to say that all of a sudden now that's a new thing when we've known it for a very long time.
Few decades.
A few decades. Question number 10, and our final question for true false. Baby aspirin is an over-the-counter medication that can prevent a certain type of high blood pressure during pregnancy.
True.
True. Love it. Okay. So I want to get into, a lot of those topics, we have tons more to talk about regarding them if we would like to, but I want to go into a little bit about you wear many hats. So yes, you are a maternal fetal medicine specialist. Yes, you are an OBGYN as far as your board certifications. You practice maternal fetal medicine. Your love is in critical care, which has always been my love. And that's where our friendship started.
That's how we connected.
Has blossomed. And I want to hear more about the business of what you're doing, which in my mind is huge right now because everyone now, I think we've known it for a while, but it's in the news about the maternal mortality rate increasing. Although we are the United States, right? We think we are doing all these great things medically, but we have this issue of maternal mortality rising. And I feel like what you're doing, which you started a while back, right? Like you're ahead of everyone with this, but what you're doing is going to make a huge difference. Can you kind of explain what you're doing?
I hope it's going to make a huge difference. So the United States is the least safe place to have a baby out of all the developed countries. By a mile.
Yeah.
This is not close.
Yeah.
So we are winning this losing race.
Yeah.
And, I've practiced maternal fetal medicine for a long time. I've taken care of a lot of really sick patients. And quite honestly, I got sick of seeing women dying or coming close to dying the same way over and over again. The same things kept repeating themselves. The same issues at different hospitals I would go to with different, different resources. It didn't matter. All the same problems just kept recurring over and over and over. And so I really felt compelled to do something about it. So I started Clinical Concepts in Obstetrics with my 2 partners. Suzanne Baird is a critical care OB nurse that's doctoral prepared with decades of experience. And Julie Arafay is also a critical care OB nurse, but is an expert in simulation. So we're interprofessional. And we go to facilities, we go to hospitals, we figure out what their issues are. There's a lot that cross over. We see a lot of themes in different facilities, and there are a lot that are unique to each facility. But we figure out what their issues are, and then we help them address those issues through education, through team training, through simulation. Some of it's through processes and writing guidelines and protocols and things along those lines. So we have that kind of consulting side of our business that we do. And then the other side is our education side, because one of my passions, and I know one of your passions, is education. And I love to teach, and we both really like to take complex stuff and make it simple. Yeah. And so we have a whole education arm to our business as well, where we not only go to facilities and hospitals and educate teams about high blood pressure in pregnancy, hemorrhage, how to manage a pregnant woman who's in cardiac arrest, et cetera. We teach all of that kind of stuff. But we also have our podcast, the Critical Care Obstetrics podcast, which is relaunching very, very soon, which has been an incredible way to connect with nurses and doctors and teach them about these concepts and help them understand this is what's happening when your patient does this, and this is how to react to it.
Yeah.
So we kind of put all of that together.
So with this too, I think that a lot of listeners and individuals watching this, they've probably heard of neonates being cared for at certain levels of care in hospitals. Like, I've had individuals say, I had to deliver at a different hospital because of the baby I was going to have, like a NICU, a neonatal ICU. How would you address the pregnant individual themselves and where they need to deliver? Because I think that that's a big question in our world, and just for a layperson and someone that is pregnant, how do they figure out and ask, and is there a way to know where they deliver?
Yeah, so our neonatal colleagues have been doing levels of care since the 70s. And basically what this means when we say levels of care, it means that the hospital has been certified, for a lack of a better word, and said, you have the resources to take care of these kind of problems. So most people know if I'm X weeks gestation, I have to deliver at this hospital versus that hospital. So like the extreme premature babies, they're not going to the small community hospitals. They're going to the big hospitals with lots of resources, lots of specialists, lots of nurses, et cetera. The maternal side, that has not been the case until about 8 years ago when the concept first got introduced. It's not a new concept. It's just a new concept for obstetric care for pregnant moms. So since that concept was introduced, maybe probably about the last 5 years, hospitals across the country have been determining and establishing their level of maternal care. And it's kind of a state-by-state basis. Like, for example, Texas and Illinois and a couple of others, many other states, I'm sure, have written their own levels of care, which they're fairly consistent across states. But basically it says, these are the types of patients and types of medical conditions that you have to be ready to take care of if you're a level 1 or level 2 or level 3 or level 4. Basically, it goes from birth center as the lowest risk all the way up to level 4, which is, think your university centers where they're doing transplants and brain surgery and heart surgery and all that kind of stuff. Most people are in between.
Yeah.
Most hospitals are in between. Now, as a patient, if you're low risk, you can pretty much deliver anywhere you choose.
Yeah.
If you have high risk conditions, it's very much going to depend. And not every state and not every hospital has completed this process. So it's a conversation with your doctor. And if you think you're high risk enough and you go to see a maternal fetal medicine specialist, you need to ask them and say, I'm planning to deliver at this hospital. Is that okay? Or do I need to consider somewhere else? At least twice a week, I tell somebody they need to deliver somebody somewhere different than they planned.
Yeah. And it's a lot to have to put on the patient, but really it is like, that's what we're trying to do, educate individuals to know the big questions to ask. Because here's the other thing, maternal deaths, would you say on average, if you had to give a high or low, how many of them are preventable?
Here's this is the good news and bad news.
I know.
Okay.
Share it.
The bad news that over 80% of maternal deaths are preventable. We could have stopped her from dying. The good news is that if most of those deaths are preventable, we've got a lot of room for improvement, and it means we can make strides in keeping women from dying. We can't save everybody, but we are not doing a good enough job right now.
And so I think that what you're doing is helping people identify things that they could change to hopefully decrease that rate of preventable deaths, hopefully decrease the rate of deaths, period, obviously. But educate individuals in those hospitals on things that they had done in the past, learn from it. How can you get better at predicting things and preventing items that you can foresee?
Yeah.
Would that be because I'm trying to think of an example of like when we say how you've seen it over and over again. For someone listening, what is it that you see as far as the most common things that could be prevented? Like what are we missing here? How could we do that?
Yeah. So first of all, we've been talking about how common this is, but it's really about 700 women per year, give or take, in the United States. So it's not like it's 7,000 per year. Okay. So it's under 1,000 women are dying in the United States per year. That's too many. Okay. That's too many. And if we believe that data, then about 500 to 600 of them are preventable, roughly. Okay. Right. So that's a lot of women, and we have got a lot to do. About a third of women, if you're going to die during pregnancy, this is such a morbid topic, but most of the maternal deaths they're split. So about a third are going to happen before delivery, about a third happen essentially while you're in the hospital for your delivery, and about a third happen after you give birth. So the causes tend to change depending on when the births are happening. Yeah. Most people think of mom dying in pregnancy, it happened during childbirth at that time. Those causes of death are typically things like a hemorrhage. So someone's bleeding. When you are giving birth, you can bleed a lot very quickly. It's like a gunshot wound or a car accident or severe trauma. It is a lot of blood very quickly. So the hospital and the teams have to be prepared to get blood into you super fast. And that blood bank is not on labor and delivery. It's in another location in the hospital. So these are the things that teams are required to practice. They have to work through, et cetera. Other causes, not treating high blood pressure. This one drives me nuts because a lot of women have high blood pressure and it needs to be treated. I think the reason this doesn't happen is less than the hemorrhage. Like the hemorrhage, we see someone bleeding, we react, and maybe we're just not reacting fast enough or whatever it may be. But with high blood pressure, it's typically because the mom might feel fine. She may not be complaining of everything, but she can still have a stroke. So we need to treat the high blood pressure issues. So, and then lastly, I would say blood clots.
Yeah.
Making sure that we don't get blood clots in the legs that travel to the lungs.
And that brings me into kind of an interesting topic that we, as physicians, if you are part of like, I want to get this magazine or this just journal, they sometimes will send you information on a weekly basis, a daily basis that are just like things that show up in the news. And I see things in the news all the time and it blows my mind. And so I have
how is this newsworthy?
Right. Like some of these articles here that I've put together, and we're going to try to maybe thumb through a couple of them just for topics to discuss because I love picking Dr. Martin's brain anytime she is nearby. And even when she's not, I'll text her and call her. But one of them is mentioning about we should check blood pressures on all pregnant individuals, even into the postpartum period. And I'm like, yes, we should. That's not new information. And then another one is like hypertension in pregnancy can lead to strokes. And I'm like, yes, it can. But it's being missed. And one of the articles mentions, and this happens when I talk to some OBGYNs, they're like, she's pregnant, it's fine. That is not the answer for someone who is hypertensive. Like being pregnant doesn't just make you hypertensive. But why is it that we are neglecting pregnant individuals and brushing off things and saying, that's because of the pregnancy? Why do you think that is?
So I talk a lot about normalizing the abnormal, which is the simple terms for normalization of deviance. And the bottom line is that if you see something abnormal enough times and nothing bad happens, then your human brain becomes conditioned to believe that it's okay to ignore it. It's classic human behavior. So because we are human beings, we can't rely on every human to make the right decision. Okay, so there has to be backup. Yes, education and understanding why that's important is crucial, number one. But there has to be backups to keep the wrong thing from happening and make sure the right thing is done. And that's standardized practices so that everybody's doing the same thing all the time. There are very few exceptions to the rule, especially in obstetrics. So maybe the doc or the midwife or the family practice doctor or someone who's brand new out of training or something doesn't understand, this blood pressure is a problem and needs to be treated. Well, there needs to be a backup. The medical record alerts you. The nurse says, we don't do that here. This is what needs to happen. And here's the guideline that supports it. Anything we can do to support the right thing being done, I'm a huge fan of standardization of practice so that if this is abnormal, then this must be done. Yeah. And if you are not going to do it, you document why you're not going to do it. Yeah. Because there are exceptions. Yeah. There are times that it doesn't need to be addressed. But that's not going to save lives. Yeah. Allowing everyone to say, I don't feel like doing that right now for whatever reason, and not explaining why, that leads to deaths and damage.
And this takes me into preeclampsia because it's just, I feel like we're seeing it more and more and more. I'm not looking at a study. I see it all the time. And I'm also seeing people who have a high enough risk for preeclampsia in a current pregnancy, and their provider did not talk to them about taking a baby aspirin every day. And that irks my soul and frustrates me. And a lot of the communities I work in are high African-American, Black individuals, women of color who I feel like, and I'm seeing, are being pushed aside or not being heard as much. And just being a Black woman that is pregnant, that's enough to get you a baby aspirin.
Yeah. Here's the thing. Once you're pregnant, there are so few things we can do to change the course of the pregnancy. Once you're already pregnant, we can't make you lose weight. We can't fix your blood pressure problem. We can't, cure diabetes. We just have to manage all of that stuff. Yeah. But baby aspirin dramatically lowers the chances you're going to get a high blood pressure problem of pregnancy. Yeah. And there's really no downside to it that we know of. It doesn't have really any side effects for most people. It does not bad for the baby. So why not give baby aspirin and lower our chances? I don't understand that one either. Yeah. And I that's one of my biggest things is just like learning that. And that's on the question form too. It's like, ask your doctor, are you a candidate? Do you have any risk factors that increase your concern for preeclampsia? And am I a candidate to take a baby aspirin once a day? Yeah, because there's a lot of risk factors for preeclampsia. Yeah. Being overweight, being above 35, being a woman of color, having a history of it, having a parent or having your mom or your sister have it.
Twins, you're pregnant with twins.
Diabetes.
I mean, that gets you it, right away.
Who's not at risk for preeclampsia?
I know. There's very few. Even if it's just your first pregnancy.
Right.
And this is where it comes into about knowing the history for your family members, particularly your mother and sisters. Because if they had preeclampsia, that puts you at risk, right?
It does.
And you had mentioned that. So those are just things to kind of having the conversations, right? And knowing these things to ask.
Absolutely.
Some of the other articles, one was about folic acid, right? And in the United States Task Force, what's the big long letters?
I think it's a U.S. Preventative Services Task Force,
yes.
USPSTF.
Thank you very much. They like to give their recommendations all the time on things. I feel like usually a year or two after or 20 years later.
Yeah.
But there's a new discussion in an article that came out about they're recommending you should take folic acid before you get pregnant. Yes, you should. And there's a whole YouTube I have on that. And folic acid, tell me a little bit about why people should take it before they get pregnant. And have you also seen or heard that some birth control pills have folic acid in it? Have you seen this?
I haven't.
Iron and folic acid. I've read little bits and pieces about certain brands that have it within the birth control pill.
Yeah, iron, yes, but I didn't. I don't prescribe any birth control pills these days.
True story.
Nope, I haven't met a pregnant woman who wants them. But all joking aside, so spina bifida or neural tube defect is the second most common birth defect that we see. And we know that if you are on folic acid for several months before you get pregnant, then you can dramatically lower the chances that you will have a baby with spina bifida. To my knowledge, it is the only birth defect that we have the ability to potentially prevent. Birth defects are random. Heart defects are the most common. Spina bifida is the second most common, and we can dramatically lower the chance of you having it by being on folic acid before you're pregnant. It's too late once you're pregnant. You need to be on it once you're pregnant. The beauty is it's in prenatal vitamins. I tell patients you just need to be on some sort of a vitamin that has folic acid until you are not able to have babies anymore. That doesn't mean don't want to have babies anymore. That means not physically able. You've either been sterilized or you've gone through menopause or you're on some form of reliable birth control that you trust implicitly. But generally speaking, I say just stay on it until you are past childbearing possibilities because over half of pregnancies are not planned. That doesn't mean not desired. It just means not planned. And then it's too late. Once you're pregnant, it's too late.
Yeah. Yeah. So we talked a little bit about folic acid and I always think about that as a supplement you need to take, right? And the prenatal vitamin. I think prenatal vitamins are very hard to choose because there's so many brands out there. But one of the items that keeps coming up, particularly when COVID came around, was, hey, people should maybe take vitamin D. And a lot of people are very low in their vitamin D level, depending on where you live too, right? Like if you're not outside a lot or if you avoid the sun because you don't want to get skin cancer, right? So a lot of people are deficient in vitamin D. So for pregnancy, would you say that you would routinely want to know someone's vitamin D level?
I don't routinely screen for vitamin D levels, and it's not recommended that you do.
No.
There's a lot of data out there on vitamin D. It's very confusing. It's difficult to understand. I'm not certain that we really know the role of vitamin D because remember, there's two different kind of groups of patients when we're talking about vitamin D. There are those who are vitamin D deficient that need extra vitamin D to get into the normal range. And then there are those that want to take extra vitamin D even though they have normal levels of vitamin D. But it's kind of an epidemic right now. Everybody's vitamin D deficient. It's not rare to have low vitamin D levels. But I think the jury's still out whether or not it plays a significant role for pregnancy right now. But you don't need to be tested for it once you're pregnant.
No. And it is safe to take in pregnancy. I think that's also another question. So that's another one that I think comes up as a question from time to time as well. And we've covered mortality. We've covered what we do as MFMs. We've covered your passion and your company. What other things do you if you have this moment to talk to people and say, I want to reach out, I want to advocate, I want to help people learn, anything else? What else would you want to share with anybody?
Yeah, I think it's really important that each patient really ask themselves, what am I at risk for? Not just am I high risk, but what am I at risk for? And what do I need to be watching for? When do I need to call? When do I need to come in? Understanding what you're actually at risk for and what are the things that you need to be seen for. Be very specific. Ask for it to be written down if you need to. So for example, it's one thing to say high risk. Okay, I'm a high risk pregnant patient. But are you high risk for stillbirth? Are you high risk for a cesarean section? Are you high risk for having a baby with Down syndrome? Are you high risk for high blood pressure problems? What exactly are you high risk for? And then that will enable your doctor to say, you're high risk for preeclampsia, for stillbirth, and for having a small baby. And these are the things that I want you looking for and that you need to let me know about.
Yeah.
Because I think we forget that sometimes.
Yeah, for sure.
We assume that the patient knows it.
Yeah.
You know, we assume that I'm always surprised at how many times I'll tell a patient, if you ever feel your baby's not moving well, you need to be seen.
Mm-hmm.
And they're like, really?
Yeah.
Like it's not something, and to me, I would assume that everybody's been told that already by their OBGYN or their midwife or whatever, but that's not the case. So don't hesitate to ask what it is you're at risk for.
Yeah. I think that's a huge point,
Huge.
Like be ready to advocate for yourself.
Mm-hmm.
And that's kind of the whole point of this, right? The expanding knowledge, developing skills, impact lives, the 3 different kind of pillars that I'm trying to work with here. Today, I think we did a good job at all of those 3 things. We've expanded our knowledge on so many things, right? As I mentioned, what is an MFM? And even all the answers to the questions, we got extra information on that, which is perfect. So we've expanded our knowledge well beyond what we expected today, which is wonderful. We've developed skills. Everything Dr. Martin is saying about asking the questions. Don't be afraid to ask the questions. We've provided you with some options on ways to ask them. You can look up the advocacy assistant sheet, drlexihill.com/advocate. Excellent way to develop some skills and really get that rapport with your providers. And then impact lives. This is my favorite. And I think it's the hardest to put words behind sometimes, which is weird. But you hear all the time on the news, like, this will impact, this is an impact. And you're like, well, what is impact? And it's having an effect on something or someone. So I always like to try to finish up with, what would you say to listeners too about what they can do, anything they can do to have a positive impact on their pregnancy?
I think, first of all, we need to have realistic expectations and to communicate what your expectations actually are. And that's a conversation that takes some time, and you need to understand what you expect from the pregnancy, because if you're high risk, it may not be realistic to expect a quote perfect outcome, whatever that looks like to you. So how do we say, what is the best possible scenario here, and what can I do to make that happen? For example, if you have diabetes, are you checking your blood sugars? Are you communicating your blood sugars to your doctor? If you have high blood pressure, are you checking your blood pressures and letting them know what they are? Are you taking your medications and coming to your visits? If you've had an early birth before, are you getting your ultrasounds of your cervix? Are you, doing the things your doctor's asking you to do in order to manage your risk? Knowing that there's not, we're limited in the ways that we can impact the pregnancy. But I think, having realistic expectations and communicating those to your doctor and understanding what your role is in preventing and minimizing complications would be what I would say.
Yeah. And that is my goal, right? Like, is to try to get to that point where somebody has an individual or has Dr. Lexi helping them to understand how to do that advocating, how to express the questions that get you to that next level of having the realistic expectations and the communication and all that kind of stuff. The modules on the website are fantastic for that, because they provide exactly that for specific topics, right? So if you're high risk for whatever specific reason, you can build your own modules and figure out what questions to ask that are topics around it, which are just, I think, super helpful. So
it's great.
Hoping for that good positive impact for everybody.
I think it's going to happen.
Thank you. So I wanted to thank you, Dr. Martin, for coming in today and being a guest with us. I appreciate it so much.
Thank you, Dr. Lexi.
And check out the website, drlexihill.com. You can visit there to find out any of those modules. Currently, you can see in vitro fertilization, advanced maternal age, hypothyroidism. We got pregestational diabetes, hypertension, all the fetal things are coming soon. So much information on there. You can also check out all the videos on YouTube as well. More podcasts to come. As always, leave any comments below for something you'd like to hear about in the future, or any comments on today's video. And I look forward to seeing you later. I'm Dr. Lexi, wishing you a happy and healthy pregnancy.